Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started. Welcome to Health Reform 2.0. I'm your host, Tom Loker. We have another podcast today. The podcast today is episode 1.10. We're going to cover the years 1965 to 1980. We're calling this A System in Crisis. And I'm joined again today by my co-host and partner, Tim Henning. Today, Tim's not right here with me. Tim is in his home a couple miles away, but because of all the things going on, we couldn't get in the studio here at my house. So welcome, Tim. How are you?
I'm doing well, Tom. How are you today?
Doing pretty good. Now, you were traveling last week. You were back in a place I used to go quite a bit, Boston. Did you go to the Bull and the Finch, the Cheers bar, and have a few pops?
Well, the idea was to get in early and stay at the Custom House and do that. But unfortunately, the airlines and Mother Nature wouldn't allow that to happen. So it was in and out and a 7.5-hour flight home last night.
You know, I'm starting to think that the only thing worse than the American healthcare system is the American airlines system. And that's not American Airlines, that's all airlines. Thank you very much. So, well, today we are coming near the end of our history series, and today is probably not going to get through all that we want to do, so there's likely going to be one after this. We did promise to have it done by 1.10, but as we were putting this chapter together, we realized that it's probably going to take two. So, Tim, do you want to give everybody an idea of what we're going to talk about today and kind of get us launched into this episode?
Sure, thank you. So, again, episode 1.10. This is the very end of Chapter 6, which has taken us 3 episodes to get through. This will take us through to the end of 1980. And the reason this chapter has taken 3 episodes is there's so much meat in here during this period that kind of sets us up for what we experience today in our healthcare quagmire. So that's kind of what we're going to do to get to the next level. And the next few, we'll talk about more things that we're seeing that we're probably more familiar with than some of the historical issues, things that we can get into with Obamacare and places where we are today. So we're going to soon be into that aspect of the place in history where we are with the podcast. So let's start here in 1970, because this is going to be 1970 to 1980. And again, there's a lot here that happened in 10 years. It became clear early in 1970 that the Americans spent a great amount on healthcare, and it seemed never to be enough. Although Medicare was less than 5 years old, Congress had already been forced to hike Medicare rates, taxes, by 25%. That's taxes by 25%. Now, much of the general physicians had done historically been replaced by specialists. And we saw the rise of specialists and talk about that in the previous chapter. And they were paid by the wealthy and the very well insured because they could afford it. At this time, probably about 80% of all Americans had insurance to cover hospital bills and surgery. And only slightly more than half were covered for even part of the doctor's bill or office visits. Doctors had a financial incentive to treat patients in hospitals, where, as studies have shown, they were receiving about 50 to 60% more per hour than when were performed in identical services in their own offices. Tom, can you set the stage for the rise of the specialist insurance programs at this time and the problems that undid their effort to fix healthcare?
Sure. At this time, if you look back, according to the American Hospital Association, there were about 6,000 hospitals in the United States. That's in 1960. There are actually fewer hospitals, about 5,815 hospitals in the U.S. today. We've actually increased the number of hospitals about 45 new hospitals over the past 4 or 5 years from the last time the study was done. But by the time John F. Kennedy had taken office, and largely thanks to the Hill-Burton Act of 1948, the long problem that had existed in America of access to quality health care in the U.S. had pretty much been solved. As the discontent with just access and quality of care receded, the nation's concern moved to the cost of care issue and the breadth of services that were available for coverage. So as one problem went away, America wanted more. And by the 1970s, and despite the original intent of these programs to be supplemental coverage, that's Medicare and Medicaid, many Americans had firmly established in their own mind the expectation that the government was, in essence, saying that they were going to be guaranteed free health care. Health care had become a right in their mind, not a privilege of the rich. But the people creating the plans didn't see this trend as we do today. You know, hindsight is always 20/20, and they were focused on simply patching what was a failing system.
Yeah, I think that's interesting because people were expecting more and more. We'll talk about that in a recent campaign ad I saw last night on TV. So given all this, I guess this would give rise to the expansion of employer-based coverage that we see today. What changed? Well,
through the early part of this period, most employer-based insurance plans offered general health coverage. They offered items like basic doctor visits weren't covered, but if you had some catastrophic issue, you need to have surgery, your child had appendicitis, part of the bills were being covered. But items like maternity care, vision care, and dental care weren't typically part of the employer's paid plan in those days. Those were things, supplementals, that the individual family would buy in a separate insurance policy. Other items like cosmetic reconstructive surgery, with only rare exceptions in case of an accident with extreme disfigurement or an illness that caused a disfigurement, they weren't covered at all. And by the end of the period, this 1980s, many people remarked that the insurance was great at covering everything you had happen to you except what went wrong or what you lost. And pressure started to mount, pushed by employees on employers who were always trying to remain competitive in their job offerings, to start to expand coverage under what was then their employee plans by adding additional coverage like vision, dental, maternity, et cetera, et cetera, et cetera.
I would expect this was also being pressured by the unions, correct?
Oh, yeah, absolutely. The unions were pushing this very, very hard.
So this had to have a big effect on adding costs to care. Can you explain how this era's insurance worked?
Well, in this period of time, health insurance, like most other forms of insurance, was really a method to spread the risk of expense over time and across a large number of people. Under this concept of collective pools of risk, the insurer made a reasonable bet that the small amount of monthly payment by all the insured would accumulate into a pool of funds that would be sufficient to cover the expenses of medical treatment, because not everybody in the pool would get the same level of illness, and not all will get sick at the same time, so there would be enough money to cover everybody over time.
Yeah, I think that was the premise. Well, we have health insurance today. How was that insurance different than what we have today?
Well, the dominant form of insurance during that period, which started back in the 1940s and really rose in prominence into this period, was called indemnity-based health insurance. When you and I were just starting into this world, indemnity-based insurance was the main form of insurance. And indemnity insurance compensated beneficiaries of policies for their economic losses up to the limiting amount of the insurance policy. If the total eligible cost went over the policy limit, you were on the hook for the rest of it. So our parents, as it were, had this kind of insurance. And it generally required people like our parents to prove that the amount of their eligible expenses, you're going to hear this word eligible over and over again, so get used to it. These eligible expenses, you had to prove them before you could get the insurance company to reimburse you for the payment. You were paying the doctor. Our parents paid the doctors. They paid the hospitals. They got reimbursed after the fact by insurance companies in this period. at the beginning, as I said, this wasn't really tied to a relationship at all between the doctor and the hospital and the insurance company. It was simply reimbursement for the consumer for the money they actually spent that was part of this procedure that was eligible to be covered. And it was just like any other supply chain that existed in the world, whether you were buying blue jeans or tennis shoes or whatever. The customer paid for the product and everybody else was in the loop. And if you had a car and the car got wrecked, you pretty much paid to get your car fixed and insurance would reimburse you.
So let me ask you a quick question. Mm-hmm. In this particular model, they knew up front what they were paying, correct?
Oh, yeah. They knew because they had already gotten a price from the doctor. They knew pretty much what it was going to cost. They had estimates. Hospitals were publishing prices that they really expected to get paid. Doctors published prices that they actually expected to be paid. And it was routine that they would give discounts themselves, particularly for people that were limited in money. And one other thing, too, is in rural communities, even into the 60s and early 70s, there was still a lot of barter business because there still wasn't a huge amount of cash available to a lot of people in the world at that time. So there were still people that were getting paid, doctors and lawyers and others who were getting paid in barter. I can recall as a kid growing up, my father getting paid with oysters. And I had an uncle that was a surgeon that came down to the local hospital and did surgeries during the week. And he often got paid with sides of beef and other kind of things because people didn't all have cash. But this indemnity insurance was in these days really was geared to cover catastrophic illness. In essence, it was designed to help people not lose everything if they had a significant event like a major accident or cancer. It wasn't meant to replace life insurance, by the way. It was meant to try to help bridge the gap between what people had in incomes or savings and their unexpected medical bills. This type of insurance was not very effective, and the long-term chronic disease coverage like diabetes and things like that wasn't covered either. So doctor visits and many medications and tests weren't covered. And for most diseases like heart disease and lung cancer, which were becoming increasingly more costly and significantly exceeding policy limits, people were starting to get left behind that were coming up with things like lung cancer. Further, insurance companies' actuarial tables weren't based on a new rising cost model. They had been based on the models that existed in the 40s and 50s. And the cost of new technologies that were coming into the marketplace and new modes of treatment that were more aggressive and therefore more expensive started to drive the price up. And the insurance company actuarials were having to modify premium prices to keep up. So to give you an idea how this works, they were extending people's life and they were keeping them alive, and extending lifetime of people also extends the lifetime of treatment cost. And as an example, let me talk about in the 1970s when AIDS was first named and diagnosed. The cost of medications for an AIDS patient was about $9,000 per year, and their life expectancy, in other words, the total amount of years they were going to be covered was about 8 years, because typically an HIV and AIDS patient from diagnosis was going to die in about 8 years. So, there was a good amount of money being spent. But by 1990, the lifespan of patients had more than doubled, and the cost of treatment had also more than doubled, and this added a huge unexpected cost. We'll probably talk a little bit more about that later.
Well, that very same thing had happened with lung cancer after the Surgeon General C. Everett Koop, who we talked about, told America smoking cigarettes causes cancer. Surprise there. Diagnostic rate skyrocketed, treatments costs skyrocketed, and we spend boatloads of money finding better, more costly, more expensive treatments and earlier methods of diagnosis and treating additional years. A vicious spiral, I would assume.
Yeah, it was. And, people went from the expectation they needed to save for those rainy days, illness, catastrophic diseases, injury, to expecting insurance or government was going to make it all better. This really changed the nature of what we now expect healthcare to deliver to us. In the end, and indemnity insurance began to fail. And as far as people's expectations were concerned, there was nowhere else for them to go.
So what happened next?
Well, it was not just people's expectations that the system was failing. It wasn't just because they wanted more and the system wasn't delivering. Our system did start to fail. In fact, the whole system began to fall apart. Remember, as we said a few episodes ago, the average life expectancy in 1950 was 68.1 years of age. But by 1980, it had extended to 73.9 years of age. Overall, healthcare had improved, diagnostics and treatments had continued to expand, and the role of technologies had continued its progressive march. But a new term began to take hold in our vernacular. Before this period, people were fundamentally concerned with simply extending their lives to a reasonable age. But by 1979, people were now becoming concerned about what they called their quality of life. They recognized that the mere extension of years of life was bringing increased sickness, increased pain and suffering due to the rise of diseases of the aged that had not been seen as prevalently in the prior decades.
Yeah, I get it. This quality of life term has always kind of bothered me a little bit because sometimes I don't know what the definition of quality is. But having said that, as we extended life, as you're saying, the incidences of diseases we saw at a higher rate. And then we had to treat it at a higher rate, very expensive diseases that we didn't see before. In other words, as we extend lifespan, we saw more chronic, expensive, and more diseases surfaced.
Yes, and to treat these diseases, doctors were developing new technology, focused, highly complicated methods to treat these chronic diseases, and specialists began to emerge in various diseases and traumas-related areas. The cost and risk began to spiral in healthcare because the lower cost practitioner, the general practitioner, was being supplanted by specialists that had focused very uniquely in very specific areas, whether it was trauma surgery or breast reconstruction and augmentation after breast cancer and things like that. And they charged more money because they had more skills in these specific areas. And these costs, as they began to spiral, and with more access to money via government programs, the AMA was smart enough to start to graduate more doctors from medical school. So we were feeding more money into the system. We were developing more doctors to come into the system. And the more doctors that came in, the more specialists, because there wasn't as much GP business, general practice business. So they started to specialize to compete with the general practitioners and take money out of the system, which demanded more money.
And true to a capitalist system driven by greed, we graduated 326% more lawyers at that time as well.
Yeah, and that plays into healthcare because as the number of lawyers flooded the market, they needed to generate more work than the old professional personal referral-based system that existed could deliver. So they demanded change to the rules of ethics that lawyers operated on. They weren't allowed to advertise. The bars in the various states wouldn't let a lawyer advertise or go out and actively solicit business. It was a referral business, personal referral. And as a result, there was a lawsuit that ended up in a landmark Supreme Court decision in 1977. If you're interested in it, it's called Bates versus the State Bar of Arizona. And what happened is the American Bar Association lost the suit, and the Supreme Court ruled against them, and they were forced to capitulate. So now lawyers could solicit business and advertise. And with all this as a backdrop, it's easy to see that as the risk of medical procedures rose, all these new lawyers with their new rules and allowed advertising saw a business opportunity. So as you would expect, there was a large increase in malpractice cases, and malpractice insurance costs rose rapidly in America as well. They actually rose from $12 per person in 1950 to $187 per person in 1980.
So I think I asked you this before. This was about 5 years ago. What's the annual cost for an OBGYN's malpractice in the state of Arizona, average?
I have no earthly idea today.
$105,000 a year.
$105,000 a year. That's about what they would pay for a PA, physician's assistant.
Exactly. So in January 1970, Fortune magazine cover story summed up the growing suspicion that the nation's health care dollars were being squandered. Much of U.S. medical care, particularly the everyday business of preventing and treating routine illnesses, is inferior in quality, wastefully dispensed, and inadequately financed. That next year, President Richard Nixon announced a new national health strategy that put HMOs at the center of reform. Tom, can you please explain to the audience and myself what occurred in the healthcare at that time and the rise of the HMO?
Well, as I said, the insurance that existed in America for many years was called indemnity insurance. And we said this kind of insurance wasn't built to cover the quality of life costs that people were now demanding, nor the increased cost of care the rising technological innovations were bringing. So people were becoming disenchanted with the old indemnity insurance. There were places in that time like Kaiser Permanente and another entity similar to Kaiser that was called Ross Lewis, that's now Cigna, and they were providing alternatives to what other people were doing in the marketplace. They were providing an employee-based system that was now expanding to individuals across various markets. But they also didn't satisfy all the market wants. But the government started looking at a different way to do it, and they came up with the idea of HMOs. And they were the government's attempt to give the people a better system via what was called a Health Maintenance Act of 1973. Consumers were supposed to get additional choice. HMOs were supposed to provide a more efficient care model due to reduction of duplicated services and better negotiation with providers. And the creators of this new system really thought they would provide a better focused practice on the prevention of disease and therefore reduce the rising long-term care costs. Sadly, we now know this didn't work for very long, and soon this structure became a contributor to the rising cost problem.
Yeah, but Congress passed the HMO Act of 1973 because Paul Elwood, the, quote, father of the HMO, had looked at the Kaiser model, here we go again, which, as we have talked about, had been around for a long time and worked fairly well. From what I read in my research, the HMO was created with the promise that, one, consumers would gain additional choice in the type of coverage that they would select. You just mentioned that. HMOs theoretically would be able to provide the services in a much more efficient care model due to reduction in duplicated services and better negotiations with providers. That didn't work out either. Number three, long-term care costs would be lowered as HMOs would be better focused on the effective prevention of disease. Now we know. Well, didn't quite work out, as I said. Why not?
Well, it didn't work for a couple of reasons. First, the creators didn't consider the effect of the additional programs that the government put in place to reap more funding for the system. And by that, I mean taxes and fees that were being levied against the services and drugs provided, and how these taxes and fees would stimulate a rise in the price of services, much like the mandatory federal drug rebate programs we have today do to drug prices. Second, the prevention lowers some short-term costs, but creates a longer lifespan, which results in a rise of an ever-increasing number of chronic conditions and often costs much more money at the end of a person's life than it actually saves in the beginning when they first get the disease. Third, while Kaiser has been able to build a system that controls costs fairly well via integration, the integration between the various HMO systems doesn't exist. So Kaiser's good at integrating within Kaiser, but if you have to go to a specialist outside of Kaiser, the integration falls apart. And the healthcare system itself didn't integrate all costs and benefits across all the sources either. So within billing and within practice, people routinely get duplicated services and duplicated billings, and it didn't get better. Everything has gotten a little bit worse. Fourth, The focus on quality of life drove the expectation that insurance is also going to pay for things I want. And as we now know, the things I want cost much more money than the things I need. And combining needed care and wanted care under the same ineffective system doesn't contain costs, it now drives them up. And then to control costs, we're left with either reducing or eliminating access to the care we want or rationing of the care we need.
So yeah, we're getting into the meat of it now. So I was surprised when I did the research, what I heard when I came across this. So at this point in time, then President Richard Nixon came out in favor of a sweeping plan for a national health care insurance program. Under this proposal, employers would be required to provide private insurance to their employees, with the employer and employee sharing the cost of the premiums. A separate government system would provide exactly the same benefits for the rest of the population. Labor unions insisted that health care should be free without any cost sharing by the patient. They also wanted fee-for-service medicine to be replaced across the board with HMOs, which, on the other extreme, the AMA struggled to preserve fee-for-service payments, pushing for a Medicare plan, a plan that would have the federal government provide tax incentives to help individuals buy private indemnity insurance. Under the scheme, there would be no cost controls whatsoever. Surprise there. Yeah. But the AMA no longer represented as much of its profession as it used to. The Guild's prestige had fallen with its loss in the Medicare battle, and in the mid-1960s, membership had dropped somewhat. It's dropped quite a bit today. By 1971, only about half of all U.S. physicians belonged to the AMA. June 1974 was the beginning of the Watergate summer. We all remember that, for those that were there. Had it not been for the year of Watergate, the United States may well have had a national health insurance plan in 1974. This would be the last movement in the 1970s when any such program had any serious chance of passing. Things were improving. Diagnostic and treatments were expanding. And what I'll talk about a little later, the adoption of the CT scanner and the MRI.
And while overall individual healthcare had improved, Tim, costs were still spiraling out of control. Wilbur Mills and the House Ways and Means Committee predicted that Medicare and Medicaid's net cost to the U.S. government was going to be about $12 billion by 1990. But actually, by 1974, the actual cost was $17.35 billion, and by 1990, it was $145.69 billion. Today, this year, 2018, we're expecting Medicare and Medicaid is going to cost us about $1.137 trillion. It has risen significantly as we have moved on.
Yeah, and it continues to rise. By 1979, people were now becoming more concerned with the quality of life, and we still talk about that today. It's very part of the triple aim. The extension of years was bringing increased pain and suffering due to the rise in diseases of the aged, not seen previously in prior decades. Tom, let's talk about this new phenomenon in healthcare and how it is relative today and consuming much of our healthcare spending.
Well, it's the biggest problem with the 70s is that we moved from the 60s where we created, in effect, new entitlement programs, although let's remember they weren't created as entitlement programs. They were created as an add-on, an additional amount of money to help protect people as they got older. It wasn't meant to be a replacement for a regular insurance plan. That came a few years later when they extended it to cover the elderly completely. But it's this concept of driving for quality of life, and this period of time built this idea of expectation that we needed that the government was going to help us pay for this stuff, and that between the government and insurance, it really was never going to cost us that much money. In fact, you and I had a discussion not long ago. I have a friend of mine that told me years ago that, what Medicare is for is not for health care. And I said, what do you mean it's not for health care? When people get old, Medicare pays the bill. He goes, yeah, but what Medicare does is stop you from having to save for it, and it allows you to buy that new flat panel television and a new car and a vacation home and take a trip away, where if you were in the 60s and the 50s, people then didn't have that. They saved for these rainy days, and we've let these rainy days now feel like, oh, well, the government's going to pay for it, so I don't need to worry about it. I've had more and more people talk to me about Social Security and Medicare being their retirement program, and I just look in awe that they believe this is going to work. So we've convinced America they deserve more. We've intermingled what we want and what we need, which has driven the cost of care through the roof. And we've convinced people that any care they want, they should be able to get. I mean, it's this kind of mindset. No wonder healthcare costs are spiraling out of control. Forget the systemic problems. Just the demand alone has gone through the roof since the 1970s.
And what's interesting is that the more supply we put into the system, the more the demand goes up.
Right. And even you talked about CT scans, and we'll talk a little bit about that, I think, now. But there's a recent article that just came out that was in Aunt Minnie, and for people that don't know, Aunt Minnie is a newsletter that comes out from the Radiological Society of North America. It's written by radiologists for radiologists, and they just completed a study of patients that smoke. And, we've known since the 70s, when C. Everett Koop said smoking causes cancer, that it causes cancer. And it's one of the few indicators that actually has a significantly double-digit percentage of change in your likelihood of getting cancer. But only about 4% of the people that are chronic smokers are actually going to get CT scans when their doctor tell them to, because they just don't care. And we've got a technology that works very well in that case at diagnosing a problem, but now patients won't go do it. And then, of course, when it's not being used for the smokers, then they have to drive the business of the CT scanner by using CT scanners in place of cheaper X-rays for about anything they can, because they get a better reimbursement rate and helps them pay for the equipment.
Yeah, we're going to talk about the CT in a bit, as well as MRI, but that's true. The lung screening for cancer was really a protocol that started a little over 10 years ago.
Right. And
it's a great technique, but it's not being, utilized. And it's the same thing we see when we were in the, the women's health section. Right. We know, that ultrasound is a great answer for dense breast, which we're going to have a segment on, but no one's doing it, or no one wants to go do it. Yeah. It's kind of interesting.
Yeah. And it's you run into two problems, and they all started in the 70s. On the one hand, you've got doctors who no longer control what they get paid. They have no say in what they get paid. It's all at the benefit of the government or control of the insurance company. And if they've joined a network because they had nowhere to go, now the network is getting forced to negotiate cheaper prices. Everybody thinks they were going to get leverage, but the problem is this isn't a supply chain. The customer isn't in the loop. And with all this going on, we've built a system that we're selling more and more health care of less and less benefit for higher prices. And then when we really need the benefit, the stuff is not available because we spent the money on all these things that have marginal upside.
That's very true. Before we wrap it up, there are a couple of points here. Earlier, you mentioned the inability to share information across the channels. Well, why would they? They're competitors. This whole premise that electronic medical records is going to solve the problem. What problem does it solve? If you're in a highly integrated system like Kaiser, I think there's some great benefits to it. But it hasn't really shown to be that beneficial in even some of the best IDNs, that their hospitals don't talk to each other at all. But let's talk about the individual physician, or if you go to a specialist, you go outside that network. Why would they want to talk to each other? They're competitors.
Well, let me amplify that, because when I was working in the public health sector running a company that managed HIV and AIDS medications, we were trying to put out programs to help reduce duplicated services, and we were talking to a lot of nonprofits. And we would talk to them and say, look, I've got a system that'll help you reduce duplicated services of a patient that was treated at a competing NGO, non-governmental organization, 2 or 3 weeks ago that's homeless and drug addicted. He shows up at you. You don't necessarily need to do the same thing. And the guys looked at me with completely clear eyes and said, why would I want to do that? When he walks in the door, I do the service. It's how I get paid. And my response is, well, you're telling me you don't have enough docs to go around with the people that you need now to see. If you reduce it, you'd have enough docs. And he goes, yeah, but I wouldn't take that risk. And the other part of the problem is that while we've put online medical records, and that's become the avenue to how we're going to integrate in a patient-centered system, it isn't the medical record where the cost is, and it's not containing the cost. If we're going to do that, we have to fully coordinate, not the medical record, we have to fully coordinate all care and all benefits across all sources so that I can't bill this insurance company in full for a service provided to you and turn around and bill another insurance company for services provided to you, because the insurance company now would know that there's 2 insurance companies and would actually do a little bit more work, number one. And if I send you to a urologist who orders a PSA test after I just ordered a PSA test, that wouldn't fly either, because the care would be coordinated and the urologist would know I just ordered the PSA test, and so would the insurance company, and they would then go to the urologist that ordered the new one and say, he just had one 2 weeks before he was diagnosed with potential prostate problem. He went to you and you ordered another PSA test. Why didn't you use that one?
Let's wait till we get to the CT scanner. So,
exactly.
So, we got a lot to talk about. And I think that, this whole segment for me about transparency, about the hostile, predatory economic environment, this can go on. I think we could do another 20 episodes on that. But let's kind of wrap up here, get through up to 1980, and talk a little bit about some of the developments. Is that okay?
Sure, let's do that.
Sure. 1950, first cardiac pacemaker. And boy, that's made a lot of advances, miniaturization. My mother-in-law just got one, and it's just been, so easy to use. It's connected wirelessly. They can monitor it. It's really good. Mm-hmm. The first practical polio vaccine, we talked about that. First kidney transplant in 1954. 1951, we talked about the IBM Gibson Model 2 heart-lung machine. You better have that if you're going to have heart surgery. Mm-hmm. This the description of the DNA molecule, leading to a Nobel Prize for James Watson and Francis Crick. Right. The first oral polio vaccine you talked about. Ralph Nader publishes Unsafe at Any Speed. Look, my first car was a Corvair. And let me tell you, it couldn't go very fast. But that's how that whole thing came about.
And it also pushed a whole lot of exhaust gases into the back seat. My mother used to pick me up from school and every day, and I'd get in the back of that Corvair. She also smoked a lot. And she would drive about a quarter of a mile and have to pull over every day so I could hurl, because I was getting sick in the car. I thought it was from cigarette smoke, which is the reason I've never smoked anything in my life. So that was the benefit. But it really turned out it was from the exhaust gases leaking into the back of the car.
So speaking of that, have you listened to Blake Shelton's new hit, I Lived It? Have you heard the lyrics on that?
No.
Yeah, you need to listen to the lyrics on that. So some of the lyrics is Mama poured grease in a Crisco can. Daddy smoked Salem's with the windows up. Drink from a hose, spit in a cup. I can go on and on. I mean, if I look back at those lyrics and where I grew up, that's exactly what happened.
That was us, and you know what? We survived, and we didn't run around with antiseptic, creams on our hands every time we went outside. We developed a good immune system, and we didn't spend money on things that had no real marginal benefit. In fact, in many cases, had a negative benefit to the species as we evolve and create more of ourselves that are going to be weaker than we are.
Yeah, he talks about his grandfather putting tobacco where the yellow jacket, stung him a few times.
Yeah.
I remember that just like yesterday. 1960, the first coronary bypass operation. So, that seems like a long time ago, but not really.
Right.
1963, the vaccine for measles. 70, the vaccine for rubella. 1974 for chickenpox. 1976, Robert Jarvix, he develops a series of artificial hearts, and we'll talk about that because that's the business that my wife just came from, and we'll talk a little bit about Jarvik and how that all turned into what's today owned by Abbott, used to be Thoratec with the LVAD.
Right.
First test tube baby was born in the UK in 1978. I remember all the controversy around that. And 1978, the vaccine for meningitis. But I want to step back for a minute to two things that have shaped a great deal of what we do in diagnostics in healthcare. And they've added some extremely powerful tools, and at the same time have reaped a great deal of benefit for people, but a great deal of benefit for physicians, for hospitals, diagnostic centers, and recently they're targets of the government, and had been in 2005 with the Deficit Reduction Act of 2005. First one I want to talk about is the CT scanner or CAT scanner, and it was introduced in 1971, and that stands for Computed Actual Tomography. Before this, X-rays were 2D. You had a panel, you would do the X-ray source, you would shoot the X-ray, it would develop, it would hit the film, it would fluoresce the film, and then you develop it. It was a 2D image. That was it. So tomography comes from the Greek word tomos, meaning slice. Makes sense, right? How many slice CT scanner do you have? So that's the difference between now what we're going to do is we're going to start taking actual views of the body. It was developed by Godfrey Hounsfeld of EMI Laboratories. Now, why was that such an important thing? Because of the great story behind it. At first, he was actually dismissed as a crank. He was put aside. People didn't want to have anything to do with him. He didn't think it ever could be done. However, in 1979, he was awarded the Nobel Peace Prize. So, Tom, have any idea how the Beatles made the CT scanner possible?
I have a few ideas, but I'm going to say I have none because I want to hear you tell the story. How's that?
So it's an interesting story. We can go on, but the Beatles, their record label, whatever what's that called? The recording company that owned that
Apple.
At that time. Yeah, but now back then it was EMI Records.
Well, yeah, EMI was their first company. Yep.
The first company. So they were recording on Abbey Road, the recording studio, right? Mm-hmm. So great success, making a lot of money. EMI was into other things. They just happened to be in the recording industry. So Godfrey Hounsfeld convinced executives to take some of the proceeds from the money they were making on the Beatles and give it to him to develop the CT scanner. So you can thank the Beatles for the development of the CT scanner to some extent. Now, what's important about EMI? What did EMI turn into? Virgin Recordings, Virgin Records.
Richard Branson.
Sir Richard Branson.
Yep.
That's correct. And of course, that went on to find its way to Michael Jackson's. And I think he bought up the Beatles stuff, and now I think you're right, it's Apple, correct? Yeah.
Right.
But the CT scanner afforded some major advantages. Before the CT scanner, there were a lot of invasive things, like a barium enema, which no one ever wanted to have, where barium was put into the colon and then the x-rays were done. Barium swallow. Some really horrific brain studies that required air to be put into the brain cavity.
Which was extremely painful for days thereafter.
Exactly, and people had to be immobilized and in dark places. So I remember it because I used to have to perform them. And when the CT scanner came along, that it was like the buggy whip going away. We didn't need that stuff anymore.
Right.
And so when we talk about that, the CT scanner, today we have a saying. Everyone comes into the hospital through the CT scanner, and everyone leaves the hospital through the CT scanner. And the CT scanner is probably the most used diagnostic tool there is today when it comes to diagnostic imaging. Because it's fast, it's today they're relatively reasonably priced. They've come down in price, although you can buy some real expensive ones today, but you can get pretty much done. We had the CT wars of different slices. My slice is bigger than yours, 16, 64, 128, 256. All that did was add more dose, which is a huge issue, especially in the orbits. And we finally stabilized now, so we can do most everything we need to do in a 64 slice CT, although there's some advantages, some others as well, as a radiologist would tell you. And I'm not a radiologist, but I know a lot about CTs. The second, in 1972, was the discovery of the MRI. It was originally called NMR, or nuclear magnetic resonance. It changed later to magnetic resonance imaging, and that's what we know it as today, and I'm sure everyone's heard about it. Mm-hmm. It was discovered by Paul Letherber, and in 1975, right here in our own backyard, UCSF founded the Radiological Imaging Laboratory. So, UCSF has always been one of my focuses when I've been in my career. They have one of the finest radiology departments in the world, in my opinion. The chairman there just recently retired, is a fantastic guy. And MRI provides us a completely different advantage to some of the other modalities. It does not use ionizing radiation. It uses a magnetic field of either 1.5 Tesla or 3 Tesla, and they have others that are much higher, but they're not typically used in diagnostic imaging. That allows your molecular field, puts you in a state where everything's lined north to south, and then we use gradients to knock everything off balance, and we generate images from that. The big difference here is that it gave a completely different look to the radiologist, to the specialist, because it has a very high contrast resolution. And as CT has a high spatial resolution, the contrast resolution, that's why you hear about sports figures going in to have ligaments looked at, or torn cartilages, if you have to have a knee replaced. This is a device you use because it's looking at soft tissue.
And soft tissue is not seen by X-ray based systems.
Not well. It's improving. Right. With CT, right. It's improving quite a bit, but not to the level of, and the MRI, sophistication, right. Correct, right. The sophistication, because of different protocols you can use, allows the physician, the radiologist, to look at different structures in a different way they never could see before. And it's getting better every day. So these two things really changed the landscape. And we started seeing CT becoming routine. We see it every day today. We started seeing so many MRIs pop up on the corner because of the structures, and we'll talk about that later, of physician-owned practices that got changed later by the Stark Law. That finally the government had to put a stop to it. Anyway, we've been going on about that, but that did rise because both these things did exactly what we talked about before. It provided more supply, and some of it good, and the demand just skyrocketed. Right. So that's kind of the story behind that, and we get into that later. So that's kind of where we are with this period. Any comments before we wrap it up? Because we're going to head on into the 1980s to 2010 after this.
Well, my only comment is I think we learned a couple of things through what happened in the 1970s. Number one is we learned that as the government tries to fix healthcare, the problem is they don't really understand the integration problem of healthcare the way it existed at the time they apply to fix. And as a result, they tried to fix a system thinking they understood how it worked. It really wasn't a system. So they thought if they push lever A, they would have a reaction in lever B. What they didn't understand is lever A and lever B never touched each other. They worked all on their own. So it's one of the reasons the HMO approach was so bad and increased cost. And frankly, everything we've done since the 1950s in healthcare has done nothing to contain cost. In fact, every single thing we've done has continued to push cost higher and higher and higher. In fact, you and I are going to be giving a speech in June to Compliance Online's annual meeting, and we're going to be talking a lot about the drivers of cost and why the government can't contain cost with the programs the way they've designed them. So many of those lessons really started to be learned by the activities that they did in the 1970s and the actual negative effects it's had on the system going forward. And then the second thing is that as we've extended life, the other takeaway is, as we've extended life, we've done a great thing for individuals. We've saved their lives, we've kept them alive. But that saving of the life and keeping them alive has not always given them a good quality of life for the rest of their life, which has caused a massive increase in treatments of the secondary issues that have come up because they survived, number one. And number two is that as we've extended life, we have increased the cost of the life that has been extended at the end massively. And that's not to say we're advocating not to take care of these people and not save their lives. It's basically saying we have to understand that the idea of the extension of life does not come free. In fact, it's exponentially more expensive to extend a life 5 or 6 years than it is to let the person die at a natural death rate at the natural date. And again, we're not arguing that people shouldn't get the privilege to live longer. We're just saying we have to understand that everything we've done to extend life has actually significantly increased the cost of care.
Exactly. And I'm not sure that we've put brackets around what that word quality and, quality of life actually means. Before we wrap it up, we talk about more and more programs, and I forgot to mention it earlier. I was watching TV, which I hardly ever do, last night. I saw an ad because all these people are running for whatever they're running for out here. I love Dianne Feinstein's platform. I think she's going to the Bernie Sanders. And I'm not saying any negative thing about this, and I'm not promoting. I don't care one way or the other. But I think if I saw it right, she wants to get Medicare to people 55 and older.
Oh, yeah. Yeah, she does. And she's not alone. There's a movement to make Medicare for all, as if Medicare is a cost-effective system. We're going to talk about this more as we move forward. And Medicare is nothing wrong with Medicare for seniors. There's a better way for us to do it. It's a better way for us to provide care for everybody. Medicare for all is not necessarily one of the good ideas to take a look at. From the individual perspective, Medicare, Medicaid, those things, if you're sick and you need help, they're great. But from the societal perspective, the national perspective, and the perspective of the species itself, these things are causing us significant problems, not just cost, but viability as a species going forward. So these are things we can talk about later. I think we'll wrap it up at this point, and we'll thank everybody for coming. We hope you enjoyed the episode. We covered a lot of meat in here, although not a whole lot of topics, but this stuff is getting into our current time frame where we all live today, and it's had significant noticeable effect as opposed to some of the earlier history, which is there, but we don't notice it. Regardless of that, we're going to be having the next episode will be episode 1.11, and we will be taking us from 1980 to 2010. The title of that episode is going to be Helplessly Hoping. Its subtitle is Time to Make a Change. We hope you will join us for that, and we appreciate you listening to us. Don't forget to like us, and also please make sure you subscribe, particularly on Facebook or YouTube. Please make sure you hit the subscribe button. And again, thanks for watching and listening, and we look forward to seeing you soon. Tim, anything you want to say?
Well, I really appreciate everyone's time. I'm getting some great feedback from some current meetings I've gone to recently, and they're all on healthcare. Tom, I think we should shoot the next one from Las Vegas. I'll be there Monday through Thursday. You should come down and join us. But we should set the cameras up, shoot down on the strip, and do our next podcast from Las Vegas as Waldo is back on the road again.
Well, you figure out how to make that happen, brother, and I will be there. In the meantime, let's say goodbye to everybody, and we look forward to seeing you in about a week or so.
Thank you, everyone.
Good night. You've been listening to Health Reform 2.0 with your hosts Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit, and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.